Hi, MS Auckland. My name is Bernard. I'm a Neurology Registrar currently in my final year of training, and I'm currently based at the John Radcliffe Hospital in Oxford, but I've done my previous 2 core years of training in Auckland. I have a subspecialty interest in multiple sclerosis and autoimmune neurology, so thank you very much for letting me present this webinar to you today. I ended up doing quite a deep dive into progressive MS preparing for this talk, so I hope it's not too burdensome in terms of the science of it all. Just on the bottom right is a small picture of me, just to put a face to the name, and hopefully I'll be able to join live after the presentation. As we know, multiple sclerosis is a chronic inflammatory condition of the central nervous system, that is in the brain and the spinal cord. Multiple sclerosis is characterized by demyelination, which is a term used to describe damage to the insulation that wraps around the nerve wires and leads to poor transmission of nerve signals, leading to the signs and symptoms that's experienced. Over time, constant or repeated demyelination leads to damage of the nerve axons or wiring itself, which is thought to be currently irreparable. Now, a majority of persons with multiple sclerosis have a form of MS that is termed relapsing remitting multiple sclerosis. That is, the disease is characterized by distinct episodes of neurological dysfunction, where a person experiences what is a flare of their MS. These are relapses, and in between the relapses there's thought to be some background disease activity, but this is still within the remitting portion of the relapsing remitting MS. 85% of persons with MS have relapsing remitting MS, and so this stands that this is the most common form of multiple sclerosis. Over time, due to constant or subclinical damage of nerves and their axons, damage accumulates, and after around 15 to 20 years of ongoing disease activity, persons can enter into a different phase of MS called secondary progressive MS after starting with relapsing remitting MS. In this phase, there's not as many distinct episodes of relapse, but there is a grumbling deterioration of symptoms that a person might have accumulated during the relapsing remitting phase, or newly slowly progressive symptoms such as with walking. In 10 to 15% of persons with MS, they never start their MS journey with relapsing and remitting episodes. Instead, they have a slow and gradual neurological deterioration from the outset, but their clinical imaging and investigation suggest that they do have multiple sclerosis. These persons have a third form of MS called primary progressive MS. The aim of my talk today is to discuss the progressive forms of MS, that is the secondary progressive, but also the primary progressive forms of MS. An important distinction in progressive MS is to understand that in neurology we use two different meanings for the term progression. We have disease progression, which means continual accumulation of disease, which is usually seen radiologically, or disability progression, which is where a person with MS experiences gradual deterioration of their signs and symptoms. I'll start with secondary progressive MS. Secondary progression of relapsing remitting multiple sclerosis can be thought of the farther extreme of multiple sclerosis as a disease process. I always like showing these graphs because we're understanding more and more that there is a low grade of disease activity that occurs in relapsing remitting MS, especially in untreated disease, and actually before a person develops relapsing remitting MS. When you have a relapse, this is where demyelination exceeds the brain and the body's natural ability to compensate for lower grade damage, and hence you experience symptoms. The slope in multiple sclerosis damage continues to progress many years into the disease, and eventually that line crosses a threshold of where the brain and the body can compensate for the accumulation of damage, and hence any ongoing changes alongside accumulation of damage is translated into progressively worsening symptoms. It's not that simple in terms of the science, of course, as not everyone reliably changes to secondary progressive MS at the same time, and that the process of secondary progression may not be inflammation anymore, but it might be a neurodegenerative phase. In some histopathological studies, expanding the multiple sclerosis lesions that's seen in secondary progressive MS, there is a paucity of T and B cells that's more commonly seen in relapsing remitting active multiple sclerosis lesions. So there has to be another process causing progressive damage to the nervous system. This also impacts the treatments that can be used for disease activity, as I'll outline very soon. Because secondary progressive MS is an extension of primary progressive MS, the demographic characteristics of persons with secondary progressive MS follows that of relapsing remitting MS. There's a threefold increased risk in females, And secondary progressive MS on average occurs around 15 to 20 years following a diagnosis of relapsing remitting multiple sclerosis. I say on average, however, as there's no good way really of definitively predicting if and when a person will get secondary progression. What are the risk factors that signify a person with relapsing remitting MS may be at higher risk of secondary progression? Older age of onset of relapsing remitting MS or ongoing active MS above the age of 45 is thought to be the only predictor of progressive EDSS deterioration independent of disease activity. But other factors that are thought to portend higher risk include male gender, early high relapse frequency, a higher baseline EDSS score reflecting baseline higher disability, higher imaging disease burden, higher spinal cord disease burden, and obviously a longer active disease duration increases the risk of secondary progression. A study done by Tomasini and colleagues showed that over 6 years, in patients who reached an EDSS of 6 or above, 64% had ongoing disease activity clinically and on MRI, as opposed to only 36% in those without ongoing disease activity. Because the second phase of multiple sclerosis involves neurodegeneration, the presence of other cardiovascular disease and its risk factors such as type 2 diabetes, hypertension, and hyperlipidemia is also associated with disease progression, probably because of the cumulative damage to the nervous system because of the cerebrovascular disease on top of the damage imparted by the MS itself. So it's highly important that a person with relapsing remitting MS, as they age, they need to ensure that these are regularly checked with their general practitioner, because we want to be reducing as much damage to the nervous system from all sources as possible, so that there's a reserve that is as robust as possible in the face of the possibility of ongoing secondary progression. How does a neurologist determine that a patient has entered into a secondary progressive phase of their MS? And what are the clinical features that we can look at to suggest that there's secondary progression? Are these the same as the neurological deficits seen in relapsing remitting multiple sclerosis, where a person is more likely to get optic neuritis or focal neurological deficits such as weakness or numbness of a limb? Well, in the first instance, a person needs to have a known diagnosis of relapsing remitting MS. You can't get secondary progression without having relapsing remitting disease, so that diagnosis needs to be certain. A person with secondary progressive MS is more likely to develop a progressive myelopathy, which is a medical term for a clinical syndrome of progressive spinal cord damage and dysfunction. Persons develop a gradual weakness of both legs, and this can be preceded by or concurrently there might be progressive spasticity or stiffness of the legs. Together with numbness and incoordination of the legs, this can make walking progressively more and more difficult. Bladder and bowel issues can begin first or gradually develop at the same time as the leg symptoms. Other common symptoms seen in secondary progressive MS is the development of brainstem symptoms, including difficulty with speech and swallowing, or additionally cerebellar features with progressive difficulty coordinating, especially with their balance and their gait. A person with secondary progressive MS can still get relapsing activity, which does make the distinction between the two phases more difficult. And it's really this time overlap between relapsing remitting MS and secondary progressive MS that makes a formal distinction between the two phases so difficult. A study showed that on average there's a period of 3 years of diagnostic uncertainty when on retrospect the person with relapsing remitting MS has entered into a secondary progressive MS phase. An issue with regards to determining relapsing remitting versus secondary progressive MS is the concept of, it gets really confusing here, active secondary progressive MS and non-active secondary progressive MS. This concept has been around for a while, such as the paper that led to the creation of this graph on the slide here that outlines the concept very well. The grey bars show the relapsing remitting stage of the disease in its kind of truest form, which after a number of years becomes the dark red portion of the disease, without relapses but with gradual accumulation of disease with MRI activity when an MRI is done. And this is called the active phase with progression. The orange portion across this time period suggests ongoing relapsing activity without progression or MRI activity, and this is called the active phase without progression. Eventually, the relapsing activity and the MRI activity settles, but there's ongoing progression clinically, probably because of ongoing neurodegeneration, which is labeled not active with progression. And then eventually there's no disease activity and no progression, which is outlined in that last red phase of the graph there. Clinically, though, it's really not easy to say confidently that a person is in one exact phase. There was one large study called the Adelphi DSP study that looked at patients with secondary progressive MS as a cohort, and these patients with active secondary progressive MS were defined as having at least one relapse or a new MRI lesion within a year. These patients tended to have a lower EDSS score and thought to have a milder disease overall compared to non-active MS patients, but they had a higher change in their EDSS score over the next 1 year, suggesting that these active patients not only behave more like relapsing remitting MS, but they're also at a phase in their secondary disease where they're accumulating more and more disease per year than those with the non-active secondary progressive MS. This also highlights again the difficulty of trying to categorically group patients into these labels of relapsing remitting and secondary progressive MS, active or non-active, because the study clearly shows, like in this graph, that the disease is a spectrum. And this also, you can see why this makes it very difficult for clinicians to again label the stage that a person with MS is in. You can also see why it makes treatment quite difficult. At this phase, there's a difficult decision on treating a relapsing remitting disease with agents that don't work for secondary progressive phase. And are these treatments that are effective for relapsing remitting MS effective for slowing down secondary progression? The short answer is yes and no, because otherwise all the treatments for relapsing remitting MS would be the ones suggested for secondary progressive MS. The decision to continue treatment is also quite difficult because if disease-modifying treatment is not effective in slowing down progression, then the risk-benefit in disease-modifying treatment switches from benefit to risk. That is the risk of increased side effects. In line with this, a tricky concept is that the disease-modifying treatments for relapsing remitting MS are supposed to slow down disease progression. So inherently, if a disease-modifying treatment for relapsing remitting MS is effective, it'll reduce the chances of secondary progression in theory. There was one study that showed that the history of patients with treatment for their relapsing remitting MS is that only 18.1% of patients progressed to secondary progressive MS 17 years after disease onset. So maybe in the era of better treatments for relapsing remitting MS, which is the era that we're in now, and the concept of NEDA, this might be able to better shut down the inflammatory mechanisms that devolve into those neurodegenerative mechanisms. So there's still a lot to learn about the role of the disease-modifying treatment so that we can design medications that target those particular inflammatory and neurodegenerative processes specifically. The tricky part is that, as you've now heard, secondary progression can occur independent of some treatment. And so paradoxically, although we might see good control of disease activity, for example, on serial imaging, and there's no active new lesions, microscopically, there might still be an ongoing degree of inflammation and neurodegeneration. And so in line with this, the current suggestion is that if there's still evidence of relapsing activity or MRI disease activity in a person with relapsing remitting MS, they might actually potentially be in this active secondary progressive MS phase if there's clinical progression. So it would be reasonable to continue on with disease modifying treatment until there's thought to be progression without evidence of disease activity. And I'll elaborate more on this in a second. So, a brief look at the evidence. Mitoxantrone and interferons were the first molecule studied to assess whether they would have benefit in secondary progressive MS. With interferons, there have been some mixed results with studies in Europe showing some evidence of slowing of disease progression, but American studies showed no effect on slowing progression. A Cochrane review was done showing that it probably doesn't have any effect on disease progression at all. Studies on mitoxantrone have shown that there's benefit in patients with worsening and relapsing remitting MS, as well as secondary progressive MS. The main issue is that mitoxantrone is extremely toxic and it causes cardiotoxicity, an increased risk of leukemia, amenorrhea, alopecia, and it's harmful to a fetus, so its use can be very difficult in a majority of patients given that risk profile. Siponimod is the first medication trialed in 20 years to show some activity against disease progression in secondary MS in the EXPAND trial, which is a phase 3 trial comparing siponimod, which is a cousin of fingolimod that's well known to us, also a sphingosine 1 receptor blocker, and it works by sequestering lymphocytes and lymph nodes, preventing their entry into the brain and meninges. In EXPAND, siponimod reduced the 3-month clinical disease progression by 21% compared to placebo. Siponimod is thought to have some anti-inflammatory effects in the nervous system and also some pro-myelination effects, which is why it's thought to have some efficacy in secondary progressive MS. The patients in this trial, though, were reasonably early in their secondary progressive phase, on average being only about 16 years from the onset of their MS, and on average about 4 years into their secondary progressive phase. About 40% of patients were still getting relapsing activity, and the average EDSS was 5.4. Following this trial, siponimod was licensed for use in patients with active secondary progressive MS in the US and in Europe. There's also an ongoing study in Germany called the AMAZIA trial, which is looking at the effects of siponimod on patients with active disease over a 3-year observational phase. So the results of that will be quite interesting. Natalizumab was studied in the ASCEND trial, and it failed to show a reduction of disease progression. And there's also been a trial looking at biotin for myelin repair, in addition to standard disease-modifying therapies, but that's also shown no benefit in slowing progression. Cladribine's been approved by the FDA in the US, and that's also been suggested by the big ECTRIMS group for active SPMS, based on the reduction of progression in the CLARITY study for relapsing remitting MS. So there's no direct studies for cladribine for secondary progressive MS, so notable for a grain of salt type of thing. This is also similar for ocrelizumab, where in the sub-analysis of the landmark OPERA study, it showed that it significantly reduced disability accumulation and progression relative to interferon in a subgroup of patients with a high risk of SPMS. So this is still an underserved area of multiple sclerosis research, and we need many, many more trials to look into the secondary degenerative phase of MS, where clearly the targets are still a bit different to that of relapsing remitting MS. In New Zealand, we've also got the added challenge of bringing these medications to the public forefront so that the right patients can access these treatments for their secondary progressive phase of MS. An important factor in the management of persons with secondary progressive MS is also addressing the multi-domain worsening of symptoms. Persons with secondary progressive MS are overall more affected than those with relapsing remitting MS, so it's very important for clinicians and health staff to ask about and to look out for the symptoms that's listed on the slide here. The management of these issues isn't restricted to just your neurologist and your GP. At this phase, there's an even greater need for coordination with multiple sclerosis community specialist nurses, physiotherapists, occupational therapy, speech and language therapists, and a continual review of needs at home. And your neurologist and your general practitioner might need to involve other specialists such as a urologist, gastroenterologist, psychologists, psychiatrists, and pain specialists. Medications could be added for what we would call symptomatic treatment that addresses particular symptoms but have an effect on disease progression, as well as non-pharmacological treatments ranging from exercise and behavioral therapies, which are highly important. The ultimate goal of the detection of these issues through to their management is to help with the improvement of the quality of life of each individual and their families affected by this phase of the disease. There's also interesting work worldwide looking at technology to help persons link with their medical health providers, applications that persons with multiple sclerosis can have on their smartphone that can log their symptoms and possibly connected to a database that their neurologist or GP can review and see patterns or instances where a symptom is particularly problematic. And this can help neurologists and clinicians be a bit more suspicious to the development of the transformation from relapsing remitting to secondary progressive MS. So watch this space. It's an interesting area. We'll now move on to the more difficult entity of primary progressive multiple sclerosis. In some ways, primary progressive MS is probably the same entity as secondary progressive MS, albeit the relapsing remitting portion of the disease is not as clinically evident. There's a lot of histopathological and radiological features that are similarly seen in primary progressive MS and secondary progressive MS. In primary progressive MS, it affects males and females equally, as opposed to in relapsing remitting MS where there's a clear female predilection. They're usually diagnosed about 10 years older when a diagnosis of primary progressive MS is given, so a mean age of about 40 years of older. And this is roughly the 15 to 20 year period longer than the average age of the onset of relapsing remitting MS, which fits into the phase of secondary progression with relapsing remitting disease. Again, supporting the idea that possibly primary progressive MS could, in some persons, be just the same disease but detected later. 5% of persons with primary progressive MS can have onset of symptoms above the age of 60. The non-genetic risk factors for primary progressive MS is similar to that of relapsing remitting MS. Aging seems somewhat of an obvious risk factor when the onset of primary progressive MS seems to be slightly older than in relapsing remitting MS. There's not as many studies reviewing the effect of smoking for primary progressive MS compared to relapsing remitting MS, but it's been shown that there's a higher risk of progressive disease in smokers. What about our favorite Epstein-Barr virus? Interestingly, studies show lower titers of antibodies against EBV in patients with primary progressive MS compared to those with relapsing remitting MS. Having cardiovascular disease and its risk factors, again, is associated with disease progression, and genetic factors are also likely to play a role in some persons. What about the clinical symptoms? Are there any differences in the way that persons with primary progressive MS presents compared to persons with relapsing remitting MS? It seems that there are. In 80% of persons with primary progressive MS, the common presentation is that of progressive myelopathy. The difficulty with the progressive myelopathy picture is that it's not just progressive multiple sclerosis that causes this clinical picture, but your neurologist has to ensure that it's not caused by any other neurological conditions, including some that are genetic or hereditary. Because of this, it tends to take longer to establish a diagnosis of primary progressive MS, even when the imaging is supportive of MS. Mimicking conditions such as sarcoidosis can have particular and different treatments to that compared to MS, and genetic conditions may not have particular treatments, but that person might get access to genetic trials. And this is the same with persons with primary progressive MS. So a correct diagnosis can be tricky, but it's really, really important. The other common presentations are that of a cerebellar syndrome, which is seen in 10 to 15% of persons with primary progressive MS. And the more common presentation of optic neuritis seen in relapsing remitting multiple sclerosis is only seen in about 2% of patients or persons with primary progressive MS. As you'll see again, the three presentations here are strikingly similar to that seen in the secondary progressive stage. How do we diagnose primary progressive MS? As I just discussed, primary progressive MS can be quite a difficult diagnosis to make. The same workup for multiple sclerosis is likely to be conducted, but ultimately it's a clinical diagnosis. And what I mean by this is that your neurologist would have to take a good clinical history, they need to find the clinical signs on the examination, and they need to request the appropriate investigations, which often involves an MRI and then a lumbar puncture, alongside blood tests to make sure that what they're seeing is primary progressive MS. Or that could help detect whether this is an alternative inflammatory or a non-inflammatory condition. There is a primary progressive MS equivalent of the 2017 McDonald criteria for MS, which is outlined on the slide. Unfortunately, sometimes what's very helpful for your neurologist or any clinician is also the passage of time, as slow progression with imaging suggestive of MS is what will confirm the diagnosis of primary progressive MS. In terms of disease-modifying treatments for primary progressive MS, there are even less effective medications studied than in secondary progressive disease. Many trials have been conducted for the last 20 or so years, but no particular treatments, including those that modify disease in relapsing remitting disease, have proven helpful for primary progressive MS. One landmark study recently was the Oratorio study, which looked at comparing ocrelizumab, which many of us are familiar with, and its use in relapsing remitting MS, which works against a molecule called CD20 on B cells. The study demonstrated that ocrelizumab was effective in reducing disease progression over 24 weeks. 29% of patients on ocrelizumab progressed versus 35.7% on placebo in their 24-week outcome timeframe, which is an absolute risk reduction of about 6.5%. The study also showed that ocrelizumab had significant benefits for walking, and later subgroup analyses showed that there was an improvement in upper limb function. It also reduced, and in some cases completely stopped, the progression of MS lesions on MRI and reduced overall brain atrophy in a very select group of patients. After 6.5 years of follow-up, there was persistent reduction in disease progression in those treated with ocrelizumab compared to placebo. The differences were not as immense in the medications for relapsing remitting MS. For most measures, the difference was about 10 to 15% better in the ocrelizumab group versus placebo, but this is still a step forward in treating progressive MS. Interestingly, but not surprisingly, those that were treated with ocrelizumab earlier in their disease had a lower percentage change in MS lesion load, suggesting a greater reduction in progression with earlier treatment. An important point to note is that most patients still had ongoing disease progression though, so ocrelizumab does not stop the disease completely in the majority of patients. Even though there's a lot of positives for primary progressive MS from this trial, we have to take a look at the study population to see who this medication benefits the most as well. The average age of those in the trial was 44, a young cohort, perhaps suggesting that these persons had more reversible or perhaps more active disease at younger ages, and therefore more amenable to treatment before a non-stopping neurodegenerative phase completely kicks in. Interestingly, other trials involving other disease-modified treatments that had failed all had persons that were recruited that were slightly older than average than in the Oratorio study, which reinforces this point. The average duration of disease was 6 years from onset in the Oratorio study, again, still reasonably early in their MS journey. Persons with MS were eligible for the study only if the EDSS was between 3 and 6.5, with an average EDSS of 4.5. Why the summary of these points is important is because the Oratorio study trail highlights as well that patient selection is important to make sure that the benefits of slower progression from ocrelizumab is maximized, and a patient needs to be in a relatively earlier stage in their disease to get the most benefit gained by ocrelizumab use, but both groups are still going to progress, which is important for us to tell our patients and for persons with MS to know if they're going on ocrelizumab for MS, for progressive MS. So we're still not quite done defining the answer for progressive MS. The most common adverse effects on ocrelizumab treatment was infusion-related reactions. Infections were also increased in the ocrelizumab group, mostly throat infections, UTIs, influenza, and respiratory tract infections. There was a statistically significant increase in some cancers as well while being treated on ocrelizumab, but the absolute value was low, only about 2.3%, and this would mean that close vigilance is important in treatment, similar to that when it's used in relapsing remitting MS. From my understanding, ocrelizumab is in talks to be approved by Pharmac earlier in June of this year, and hopefully we can see the outcome of that a bit later in the year, which would be a great step towards getting it as a treatment. And of course, in persons with primary progressive MS, the management of symptoms is very, very important in the same way as that's seen in secondary progressive MS. So, kind of throughout this talk repeatedly, and one key message that I really got from reading over time into progressive multiple sclerosis as a disease is that treatment can have an effect in slowing progression, but it's treatment at the right stage of the disease that's important. If we can better detect patients who are early in their secondary or primary progressive phase when there's still active disease, then these are going to be the persons that benefit the most from treatment. In part, I think, and a lot of kind of clinicians worldwide as well think that this is because the current treatments are better aimed at the relapsing remitting style process and not quite the neurodegenerative process. It's clear that there's a whole lot more research that's needed for these phases of multiple sclerosis. And it's not just treatments, but how do we make persons with MS and their families and those that work with these persons with MS, and not just neurologists, but nurse specialists, general practitioners, how do we make each person in the chain of care for a person with MS be more aware of the development of progression sooner? What kind of technologies can we employ, including smartphone applications? There's a lot of research around the world looking into predictive algorithms and AI to help assess for progression. And although we're still heading there, I think that we will have better methods and technologies in helping define and detect either secondary or primary progression. There's a lot of research going on about understanding the molecular and histopathological differences and changes that occur in the CNS of a person with MS. And the more that we understand this process, the more that this will lead into useful biomarkers of progression and also treatments. And ultimately, the combination of more information, detection of progression, understanding of the molecular processes, this means that we'll have more and more trials looking at slowing the process of secondary or primary progression. I haven't looked too much into towards the US, but in the UK, there's a lot of trials looking at repurposing medications that have mechanisms that are thought to be helpful in slowing progression, or achieving what is called the Holy Grail, which is remyelination repair in established damage. In London at Queen Square, they're doing a multi-arm trial called Octopus, which is looking at multiple different medications at the same time to try speed up the process of finding a medication that we already know that might be helpful in multiple sclerosis. I've listed some of these medications that different groups are looking at in different trial sites, and a lot of them are medications that we already know. They're already used for a lot of different conditions. And so that's the end of my presentation. Thank you very much for letting me present this very interesting corner of neurology. I hope that was informative, and hopefully I'll be able to take any questions if I manage to get online on time. Thank you.